So the mask issue seems like it's a never-ending conversation about K95s, N95s. I'm getting a little bit tired of even hearing about it. But so this is a K90 N95, all right? Again, the K signifies that it came from China, all right? It's not an American or domestic mask, even though we might have American companies producing them in China, which then has NIOSH testing them and putting N95 on them. They're slightly different, obviously, in style. The N95s actually are molded more and they're more comfortable, which is why people like to use them. But as everybody knows, it's extremely difficult to get them. So the most important thing that I've been trying to say over and over again, so people are clear, it's the material that they're made of that's the most important thing. These are melt-blown cloth, all right? And that means that it filters out the virus. So the KN95s that M&A is getting their hands on, we've already vetted them through epidemiologists. These are good. The cloth is good. Here's the problem, as everybody knows. They're all different. It's usually you can get small, medium, large. There's different styles, fit people differently. You try to get it as tight as you can to the face. You don't want any air getting through. Not so easy when you have one mask, bunch of different faces. But what I would say to people is because of the elastics, you need to get these things on. I'm just going to put it on as tight as you can, molding it to your nose. And as it is, if I put these over my ears, it would never fit tight. It's got to go all the way up to my head to get a tight fit. So what we've been looking at is you need to get these things so that you put a band up to the top of your head. Some people have been doing it with a paper clip. Some people have been doing it with a headband, getting it off their ears, and just use the headband going up through the loops instead. You literally put the headband through the loops, tie that around your head so it's off your ears and really tight to your face. For the actual part of your bridge, some ideas that people have come up with that I think is really good. Patients who have been on BiPAP and you have to have that mask on them really tight and that it's uncomfortable for the patients as well as they're on it all the time. There's adhesive material that you can put right onto the skin itself that we use for the patients, suggesting that it's a good idea just because of the abrasion and tightness that people are getting, get it off your ears and then use that adhesive over the top of your bridge, to the top of your cheeks. That will help get you a seal on the mask and also save some of you. We've already seen the pictures of a lot of people not even getting bruised, but getting just abrasions off the top of their nose and off their face, which isn't good when you're trying to avoid getting a virus. So those are some suggestions right away that people are giving, and I would encourage you, if you guys have come up with some MacGyver solutions of your own, please share them with us because we're putting them out to the rest of the nurses. As far as these masks, we have regular shipments coming in that we're trying to distribute so that we can supplement the supply. I will tell you that New York, I'm in contact with them on a regular basis because they seem to be about 10 days to 2 weeks ahead of us, so I like to hear what's going on so we can get the benefit of that. They have passed through their governor an executive order that now is a regulation requiring that any healthcare worker in a hospital that requests a mask must get a new N95 each day, which is great. We are going to push that here as well because we're finding that it's still disparate across the systems. As you guys well know, we view it then since it was commingling and everything else went on, that you have to treat every patient as if they're COVID positive and therefore N95 should be on everybody. That's not happening, so we like that regulation. We think New York realized that that was really what they had to do. Almost all of their hospitals became 90% COVID patients anyway. And we're in the surge now, so more important than ever that we're not giving it to each other and giving it to our patients as well. So I think we want to push that regulation. And as far as other personal protective equipment, we also had ordered face shields. They're becoming more readily available because Apple and Gillette here and some others are actually mass producing them, so that should be a little bit of relief. Gowns are problematic, but apparently on the way through several companies. But I think we'll continue to order the masks. I think having them changed out regularly as possible would be desirable. And the face shields we're going to start distributing as well, just to make sure that even outside of the just COVID units, but anywhere else, that people can get that protective equipment on. So you'll start seeing that distribution happening as well. Because of the shortage, there's a number of places trying to clean the N95s, and they're experiencing different types. One is UV lighting is one. Another one that people have probably read about is the Battelle system, in which it's using hydrogen peroxide to clean them. still, we remain really suspect of this, and that the preference is to get a new N95 on you, which is why we're ordering them too and trying to supplement, and we're happy to see the New York regulation that says you should get a new one basically each day, which would be equivalent to each shift, so that you can toss the other one away. I think that's appropriate. So at this point, we're pushing that, mostly because even under the system, the research is coming in saying that this may be, particularly on the hydrogen peroxide system, might be something that works. But it's a big difference between might be to using it now. If the research is good, that it kills off the virus, and the hydrogen peroxide is a low enough level to be acceptable occupational-wise, that's all well and good, but it doesn't test over the long term what the effects are of the material in the cloth and whether or not you're breathing it in over the long term. It's still experimental, and therefore our view is, look, if you were going to try to do an experimental system, you would get consent from people first. You wouldn't just give it to them and make them do it. So we don't really think it's bad enough out there that we don't have the right equipment. I think it would only be insult to injury to now have people using something that's experimental, and we can't give them a sense of confidence that there isn't any other collateral effect of using it after the fact. So we're pushing not to do it. And that N95s, really the issue is to get the manufacturing up and to get new N95s into the hands of the healthcare workers. That's the appropriate way to handle it. So yes, some places are still doing it, don't really like it very much, continuing to push against it. And the ones that are doing the Battelle system, some are using it, others I think are just storing them, using as a backup in case they run out of new N95s, which at least that would be better. It's one thing to say we have nothing at all versus this, as opposed to we're going to use this as a regular system instead of using clean N95s. Yeah, big problem everywhere. As the request was to actually shut down all the elective surgery places and all the other non-essential areas so that we could get all the space available for COVID patients, retrain everybody up in order to assist with the surge that was expected, and the surge is upon us. Now, I think people have probably read that Massachusetts is considered a hot spot. It's, I think, third in the nation now, and one of the highest incidences in terms of geographic density. So we're right in the middle of it now. So as far as going to different locations, we all knew that this was going to be something that was very difficult, so we're looking to retrain the people that would otherwise be in the OR or different elective surgery, ambulatory care, other clinics or whatever. Could they be trained up in order to assist the ICU nurses? And the PACU, I think, have largely, those been switched over to intensive care units, and they're functioning as ICUs now. What we learned in New York in the midst of all the difficulty that they had is, yeah, that system works well, and if you train them up and they're familiar with who they're working with and the space that they're working in, they can do either a dyad system where they're buddied up or a variety of different systems. They do proning teams where a whole group is designated as the proning team and they're trained, so when they go to prone a patient, there's a group of people that know exactly what's expected and how to do it safely. And if it's done effectively, there's very little chance of extubating that patient, and the proning works really, really well. And in some cases, they're proning without, the patient being intubated and trying to avoid having to tube the patient. So the proning teams, training people up for that, training people up to be runners, training up to people to be observers for the donning and doffing of PPE, and just training them up to be a buddy system task-oriented inside the ICU. There's lots of nurses who can do many, many aspects of the care, but can't take independent responsibility of the patient. And that's the key. There should not be a case where you would not feel comfortable taking an independent assignment. If that's the case, you should not be picking up that assignment. You should be the buddy system, the runner, all of these other things that will be instrumental in allowing the critical care nurses to be able to take a wider swath of patients than we would ever have wanted to expect them to, but nonetheless, in the middle of a pandemic, that's exactly where we're at. So as far as if we do it that way, we think, no, you're not putting your license on the line because you're not accepting the assignment. You're doing tasks appropriate to your skill level, and that's the way it should be. As far as the nurses having to take a much larger assignment than they should normally take, I think everybody's well aware that the mandatory overtime has been waived under the law, and so haven't the limits on the patient assignments in the intensive care units. That's a law in Massachusetts. That was waived as well. So we're going beyond those numbers that we normally should. What has happened, though, as well as that, is there's been a law that was passed, actually, I think it was Friday night, the governor signed it, which is a liability waiver law. So On that end, you will not be deemed liable for anything that's going to happen here under these types of circumstances where you're spread so wide, so thin, that you can only do the very best you can. So normal standards of care of what you would expected to be doing in terms of these patients, the things that you just couldn't possibly get to at this point, nobody's going to expect you to do that. They're going to expect you to do the very best you can in this circumstance to help these patients survive, and can't expect you to be able to do normal types of standards of care under these assignment loads. So that has passed, and I think that's good news for everybody as well. Yeah, testing remains a big problem and extremely different from system to system, which is a problem in and of itself. I think that one thing that we're going to find after all of this is that it's a huge part of this issue, is that there doesn't seem to be a centralized, clear system of a singular guidance. It's kind of like this panacea of choices out there, and that's really not how to work best in this pandemic. I mean, they need a singular way of doing things. But that's not where we're at right now, so we're kind of jimmy-rigging everything, and testing seems to be adopted very differently from system to system, in part because availability. You know, we have large systems that have the ability to do the test on site. Other systems don't have that ability. And then we have a variety of interpretations of the guidance and how that's being handled. So it is a big problem. Our view of it is that if a nurse wants to and believes she's been exposed, he or she should be allowed to be tested, and that should be true of any healthcare worker. The big problem we have, is everybody knows, is this asking if you're symptomatic and then only allowing you to be tested if you are symptomatic kind of misses the boat by a big lot. At the end of the day, everybody's aware of the research that indicates that some people are not symptomatic at all, number one. That's a big problem. Other people have variations in the symptoms, and the fever may happen in some and may not happen in others at all. It also is true that it might be 4 or 5 days before you even show symptoms, and yet you're shedding the virus at a very high rate. You're very contagious during the time when you're not symptomatic. So if somebody's been exposed, then yeah, I can understand why they want to be tested, not only because they want to know for themselves, for their family, and also for their coworkers and their other patients. All the more important why we're saying the PPE needs to be handled well, because if everybody's in PPE, at least we have lesser risk of exposing each other. But nonetheless, we are still going to take off that PPE and end up having lunch, or having a quick break and a cup of coffee, or talking to each other without being in full garb. In those moments, we are putting each other at risk as healthcare workers. So yes, it's extremely important that people get tested. We are pushing that with the state at this point. On a weekly basis, we have a phone call with the state to go over our request over those issues that need to be handled in the coming week. And one of the ones that we've been harping away on is the testing of healthcare workers. And we've suggested that people should be tested on site with a 15-minute turn. There is a test now that gives you a 15-minute result. The quicker the result, the better. And we're saying for those places that may not be able to do that for some reason on site, then the other suggestion is that where you can go into the drive-up to make those more plentiful in terms of throughout the state, but also possibly give a certain period of time during the day that they are healthcare worker only, and therefore you can drive up as a healthcare worker, show your badge, get tested, and know. And you can, I think, have a little bit ease of whether or not you're spreading it all around to your other colleagues or spreading it around to your family, or for that matter, some patients that may not be COVID positive, that you just don't want to give it to then as well. So yeah, testing, we're pushing on it over and over and over again. We think it should be more readily available to everybody. You know, it can be easy under really stressful circumstances sometimes to get turn on each other, if you will. You know, the employer pushing things that are uncomfortable for people can cause people to lash out at one another. I haven't seen that so much, but I do see that there's an impetus to try to make that happen. And I just remind people, there's nobody else that you're in this with but each other together. And that's what you've got. You've got to rely upon each other. You've got, you have people that are working the OR, that have never worked in an ICU, and they're with you, trying to do the very best they can. They understand they're not capable of taking the full assignment, but they're trying to help any way they can. And they're doing their best, and I know you're doing your best as the ICU nurses and the ED nurses or whatever, and we really need to know that we're trying to have each other's backs and to not let anybody try to get in between us. It's very stressful, and I think there's going to be need to support you after this is all over, and we need to start thinking now about the next wave. which is going to be in the fall, and our best thinking about what we do in order to protect one another from how to best plan for that, how to make sure that we have everything that we need in order to do this better when we know we can expect it coming up in the fall. You know, I had a call from a nurse that's actually not in an M&A facility. We've gotten calls from just, you name it. We've gotten calls from every different type of health environment who appreciate so much on the unionized nurses really being unafraid to get out there and speak out in the press for what everybody is thinking and experiencing, but they're so afraid to bring it up themselves for fear of retaliation, that the M&A nurses are really speaking to it out there in the press every which way they can. And so we're getting a lot of phone calls, I think, trying to make sure that, hey, could you raise this, could you raise that, could you, and so that's great. But one nurse in particular called, and you know, I know this isn't, she's not alone in this experience, but they had a colleague in their hospital that ended up being positive for COVID, wasn't doing well, ended up admitted to the hospital and did not do well at all, and got transferred to another hospital and ended up passing away over, not this last weekend, but the weekend before. You know, that is devastating for nurses to know they lost one of their own. And then to feel so vulnerable in the hospital yourself. Are you yourself? They want to be tested. They want to know, am I giving it to each other? Am I giving it to my family? You know, am I giving it to other patients that might not yet have it? And to be told, well, you don't have symptoms, so you can't be tested. I mean, that's just really hard, right, for everybody. And that's why I say, as I said before, man, you only have each other's backs. So support one another. And by all means, let us know, because we will definitely be at the state and all over them on a regular basis to get as much as we can into the hospitals, whether they're M&A or not. We certainly hear from all of our members, and they're speaking out to the press. But if you don't feel like you have a voice, we can certainly help you develop one, because every patient, doesn't matter where you are, they're somebody's family member, and they need to get the best care possible. And you need to be able to do it safely. So yeah, have each other's back. It's tough out there. And we know that we probably got about another week or two of where we are in the surge before. I think it's going to get experienced a little bit different across the state. Boston's in the height of it now, but I think the North Shore's got a higher percentage, and South Shore as well. And then as we go out towards the Worcester and Western Mass, less so. But I think everybody's going to experience it to some degree. And keep in mind, it's not all hospitals. We have folks in the behavioral health units that are really in a difficult situation with their patients because they don't have a lot of the equipment available, and their patients have a really, really difficult time being able to comply with everything. They're not used to these things, and they're just, it's like a petri dish that they're in right now for this COVID. So they are really suffering as well. And we wouldn't normally, we think of the hospitals and everybody in the hospital, but this thing's got its grips on everybody in all different walks of life and all different health facilities. So we need to try to do as much as we can to support one another and get whatever messaging we need out, whatever you guys need, get it to me, and we'll fight for it for sure.